Hey everyone, it's Naomi Wolf of Daily Clout, and we're here with yet another Profile in Courage. Kelly Brown, who is from the world of finance. He is an investor for others, and now he's an investor for himself, and he lives in Toronto, Canada. And I reached out to him because he was being vocal and outspoken online about his view of lockdown. So welcome, Kelly.
Thank you, Naomi. It's great to be here today, and Profiles in Courage is a great name for the show.
Thank you. We totally stole it from John F. Kennedy Jr., but we figure it's time to dust that off again because it's definitely a crisis. So what led you to speak out? I know that I get the sense that in Canada there's a strong kind of consensus that, at least from the top down, that these very draconian restrictions shouldn't be criticized. So I think it takes special courage forward, as two of our other Profiles in Courage have done, Dr. Patrick Phillips of Ontario and Sarah Robinson. So you're the third Canadian, and we have another Canadian member of Parliament coming forward onto our platform soon. So what led you to speak up and express your views about this, and what are your views?
Well, it's a great question, Naomi, and I like the way you framed it, and I think the way that I'm feeling is similar to the way that a lot of other people are feeling. And, many people, we all acknowledge that there's a pandemic, there's a virus out there that's taken a lot of lives. But there is the other side of the coin, that the lockdown measures, the public policy is really creating a lot of collateral harm in many different forms. And I think as humans, I think we all sense this. We're all smart. We're all human, and we can sense it. And so I thought, given my background in finance and in investing, that leans the style of investing that I do leans itself to a lot of analytical rigor. And throughout the course of this last 12 months, I've taken that skill set and applied it to a lot of the data that governments and jurisdictions put out, which is very good. There's a lot to analyze and to sort of come up with, what my view is in terms of what the data tells me about everything to do with COVID-19.
Well, let me jump in and interrupt. Forgive me for interrupting, but when you describe the kind of research you do as an investor, what kinds of things do you usually look for? I assume you're looking at numbers that a company has. What's their output? What are their expenses? What's their profit margin? Is it going up or down? Like, you're used to looking at data streams, right, to make judgments about what companies to invest in. Is that correct?
Yeah, that's a great way to describe it. So you're taking, as a investor in public companies, you're taking the information that's given to you, both the financial information and the say industry information, and it's not overly complicated math. You're just you're dissecting it and trying to figure out what it's telling you,
right.
And in order to make a decision about whether or not a company is a good company and whether or not to invest and at what price and all of those things.
So let me also jump in now and say that, I've been drilling down into the COVID maps, and it's the exact same kind of math, right? Our elected officials are taking these data sets of infections and deaths, and they're saying, look at these numbers. Based on these numbers, we're going to take these policies, which is really analogous to an investor saying, we're going to emphasize this or that, investment. So what is really, really important is for citizens to be able to look at the raw data and understand the sources of the data and the methodologies that are being used to arrive at this number of infections, this number of deaths, other metrics, the usual metrics that the media reproduce. So what data sets have you been looking at, and what have you found related to coronavirus?
Well, so great characterization. So essentially, the headline information around the central issue, in my view, is the headline information around mortality risk of COVID is not properly portrayed, in my view, by the government and the media. And so essentially what that means, and I'm not the first person to say this, which is while anybody can get infected with COVID-19, the risk of a bad outcome or risk of mortality or risk of hospitalization is extremely age stratified. And that's a data nuance that doesn't get talked about enough. And so, for example, Martin Kuldorf a well-known scientist, often says that the mortality risk between the oldest and the youngest ages is 1,000-fold.
Wow.
And so we know where the mortality risk truly is, but it doesn't seem like public policy is behaving in a manner that addresses that, which then should allow the rest of society to operate in a much more normal fashion, because the great majority of society is not at large risk of a bad outcome from COVID, and no more than a very bad flu season. Right. So wow. This is a concerning issue, and actually the reason why I sort of got into the data myself originally was I wanted to know what my own risk was. Right. I wanted to know, and the risk of my parents. I wanted to know how scared I needed to be walking down the street, because I think the headline number is that 2.5% of all cases, roughly, are fatal. But when you dig into it, you see that that's extremely age stratified, and young children under the age of 19 are not at risk, and people my age are not at risk of a very bad outcome. And I shouldn't say no risk, but the risk is very low. And so digging into that, it made me feel a lot more comfortable walking down the street, and that was a good feeling. It was a nice wake up for me. And so I wanted to share that message.
So Kelly, this is so important, and I just want to chime in with a few extra notes about people you've mentioned. Professor Martin Kuldorf is a virologist, immunologist, I should say, at Harvard, who's one of the signatories of the Great Barrington Declaration. I'm actually here at AIER in Great Barrington, where the declaration was signed. So I've had the pleasure of speaking to Dr. Kuldorf, and I've been very impressed with, what dedicated scientists he and his colleagues are in making that point that they made in the Great Barrington Declaration, which is this is really age stratified, and their argument, which now there have been, I think, 7,000 signatories, or I'll check that, but hundreds of signatories, their argument is this is so age stratified that really we should let society open up for everyone under the age of 70, and let people who are really elderly support them in isolating if they want to, and it should be a matter of choice. So other people, these scientists were really targeted and smeared and attacked and called conspiracy theorists, but now I see other, the data is coming in, the science is coming in, and other policymakers are facing the fact, and you're validating as well from a different perspective and different optics, that this is in fact the case. I looked at tables that were generated by a community member who seems to have done what you did, and I want to ask you about your method in a minute, but he showed me breakdowns from Massachusetts, where I live half the time, and it blew my mind, maybe the way your mind got blown in looking at what happens when you stratify these mortality rates and infection rates by age, because what I saw was that the average age of an infection was in the mid-40s in Massachusetts. But what's an infection, right? Like, people get sick, they stay home, they feel bad, and hopefully they don't have worse outcomes, but they're not hospitalized. But the average age of hospitalization in Massachusetts was 74, and the average age of fatalities from COVID was 80 years old in Massachusetts. So these were, every death is tragic, but these are people who are at risk of dying of many things.
Well,
right.
Yes.
Sorry, I just want to jump in with one more data point. I also saw a breakdown of fatalities in Canada by age, and maybe you sent it to me, and it showed that between 0 and 19, there has been one fatality in Canada, a nation of millions and millions of people from coronavirus. And as we know, those fatalities often have comorbidities or are recorded as with COVID if there was a positive COVID test. And now I'm sure you've been following the COVID tests, PCR tests are subject to false positives. So I felt very relieved as a healthy 58-year-old, not that I'm going to be rash or take unnecessary risks, but my sense of should universities open up, should schools open up, should shopping on high streets and main streets, which is killing small business, open up? The answer really has to be, yes, under most circumstances. So there, Kelly, I just wanted to hand it over to you.
No, that's all so accurate. So just to give you a quick stat, so in the city of Toronto, the percentage of the population above 70 is about 11%. The population over 70 accounts for about 83 to 86% of all hospitalizations, of 83 to 86% of the mortality and about 50% of the hospitalizations. So 11% of the population accounts for at least 83% of the mortality. Now, you could say, well, what about the other 17%? There's still a lot of mortality there, and I think the point is that other 17% occurs at such a low case fatality rate. So a massive number of cases contributed to that other 17% of the deaths, and so that really sort of illustrates the nuance. And you're right about mortality in young ages. I can't speak to the entire Canadian data under 19, but I'm very familiar with the Ontario data. And we have 2 fatalities, coded COVID positive fatalities in the under 19 age group, the school ages. And both of those, so the one occurred, I think in the summer, it was unclear whether that fatality was actually of COVID. And I believe there was some other accident, and the second one that just occurred recently, there's some confusion around the cause of death there. So we may have 0. The number may actually be 0. And in addition, and so that sort of brings us around to the topic of the collateral harm and the fact that schools are closed.
So what do you see as collateral harms, unless there's another point you want to make about the data you saw when you broke it out by age?
Well, I think, one of the biggest collateral harms to me are the school closures. It is. Say that again?
Let's talk about that.
Well, so I think, so if we look at the data in schools, we have, there's a lot of concern with school reopening and doing it safely, and it should be done safely. But if we take a step back, in Ontario, we have had only one teacher die of COVID, and no students die of COVID, it would appear. And so that, to me, really strikes at the heart of whether schools are safe. There's a lot of discussion around whether schools are vectors for transmission, and I'm sure they are, but do they result in widespread mortality? I think the answer is a clear no. And I just don't...
And ask, Kelly, if I may, did you find out whether that one teacher, and again, every death, of course, is tragic, but did you find out if that one teacher died of COVID or with a positive COVID test and another possible cause of death?
So it would appear that this was a death of COVID. It was a 67-year-old woman that had a comorbidity. And so it does happen. It can happen, but I don't think that it's happening at a rate that justifies entire school shutdowns. I think that's the point.
Let me jump in and say, again, every death is tragic, but in 2017 in the United States, 70,000 people died from pneumonia or the flu. And so it's not as if before COVID we lived in a world in which people never died of respiratory infections that were airborne. They did, sadly. So one of the things we're seeing in analyses of data in multiple countries is that other causes of death are vanishing, like flu deaths are vanishing in various metrics. The CDC in my country has collapsed pneumonia, influenza, and COVID into one category. And so what used to be tens of thousands of flu deaths in the United States are no longer visible. The CDC is estimating them, and they're being, and flu is vanishing in other dashboards. So it's very, very sad, but it does, this call for zero COVID, which I've started to hear around the world now that the PCR tests have been hopefully adjusted, and we're going to see a drop in infections and possibly even fatalities listed as COVID. This drive for zero flu, zero pneumonia, zero coronavirus, which is, every flu, every cold is a coronavirus, or many of them are. That's a bizarre thing to aim for, because we live in a world of pathogens, and sadly people do die of flu. I didn't mean to minimize it, but just to say, I wonder what in a normal year, the deaths would be from pneumonia or flu in a 67-year-old person with comorbidities. No disrespect to her. The other thing I really want to share with you about schools is that I've looked at the main studies that the media spins as school transmission. And when you really read the peer-reviewed studies, your world changes, because that study was spun as teachers are getting sick from students. But when you really looked at how the study was done, they took a large group of students and a large group of teachers, and yes, they went to the same daycare center, but the study never showed that the kids who were positive infected the teachers who were positive. It just showed that in this big group of students and teachers, some people tested positive in both groups, and the teachers had sick people at home in their households. So I just wanted to say, and I'll stop talking, give you the floor. The narrative of infection is that it's like DNA, and that you stop whatever that crackling sound is, please. I'm going to say that again. It's like DNA at a crime scene. The narrative about coronavirus transmission is that it's like DNA at a crime scene, and you can tell exactly where this virus jumped into this body and what the address is. But we know that that's not true. So the studies that are spun as showing transmission in schools really haven't proven that. They've just proven that there were teachers, two of which turned out to have sick people at home, and there were students, some of whom tested positive. So now go on to your other collateral harms that you're worried about in addition to schools.
Well, of course, businesses, Main Street, people's mental health. I think that it's a laundry list. I think it's been well documented and well talked about that this is a very unnatural experiment that we're conducting in society. And we've seen that there was peculiarly there was some excess mortality in younger age groups here in the summer in Ontario and in Canada. Some data that was just released on Statistics Canada showing that in younger ages, 0 to 44 ages, that there was some excess mortality through the summer that you would not expect. And that was really shocking to see. I know. And just I think one last point on, it's related to schools, but also generally, I think to what we're seeing, in my view, is we're seeing a real myopic focus on case infections as opposed to risk of mortality. We're focused on cases and not mortality.
Right.
It's true that anyone can get infected, and it's true that, I suppose it's true that a youngster could get infected at school and take it home to grandma. That's a scenario that has to be managed accordingly. But it's not a scenario that should be managed by locking down all of society. I think that's the main crux. And so what's concerning to me about the focus on cases versus focusing on mortality and where it exists is it's improperly informing not only the lockdown policy to date, but it seems to me like it's improperly focusing the exit strategy out of the pandemic and the vaccination strategy. So in other words, if we know where the mortality risk exists, remember I said, 11% of the population over 70 in Toronto, 83% of the fatalities. Well, in order to reduce, assuming vaccines are effective, it strikes me as obvious that you don't have to vaccinate the great majority of the population to eliminate much of the great majority of the mortality.
Right.
So I posted about this on Twitter the other day. There was something really concerning that came out of the city of Toronto. Some of the dialogue, and you can see it. The chief doctor in Toronto was talking about new normal not until, sorry, I don't want to misconstrue her words, but basically saying we need to vaccinate 60, 70, the majority of the population before we can contemplate going back to normal. And that doesn't strike me as making sense, because, I mean, if you want to reduce cases, then I suppose that makes sense. But if you want to reduce mortality, I think you need to focus the efforts. And we have enough vaccines in the province to vaccinate all of the long-term care residents, which is where, unfortunately, tragically, much of the mortality has been. Right. So it's been troubling to me, and that's partially why I've come out so vocally, just and rationally and unemotionally with the data itself. It tells a real story. It shows where the mortality risk is, and we're unfocused, in my view.
So that makes very, very good sense. And I just want to say that the vaccine itself, according to its manufacturers, doesn't stop transmission. It addresses symptoms. So you're absolutely right that it makes sense to vaccinate elderly people to minimize their symptoms, or to protect the symptoms if, God forbid, they were to get sick, because they are in danger of being hospitalized and dying. But you're also right. I mean, the flip side of this push to vaccinate everyone, or 70% of Torontonians, really worries me as well, because people like Martin Kuldorf keep trying to remind us what the human immune system does, as we learned in 8th grade, or at least people of my generation did. And that is, it's good, according to Martin Kuldorf, it's good for younger, healthier people to be exposed to the virus, and even to get COVID and recover. He says that it is good, because then we as a species, as a group, evolve so that our systems recognize the virus and it protects us. Whereas if we're all indoors, we're not developing those protections from the virus. And if we're all kept from being exposed to the virus, our immune systems never habituate to it. It never learns to live with us, and our immune systems never learn to live with it. So are there other anomalies that you saw in the data? What do you think, has your thinking about the numbers of infections, for instance, changed if you've been following the PCR test scandal, that the World Health Organization has said that the cycles are too high and they need to be going off?
Well, I wish I could weigh in on that end of the debate, but I probably shouldn't. It's not my domain expertise, and
don't worry about it. Is there anything else apart from the age bracketing that you did? Or is that your main focus, the bracketing of the age?
It's an interesting question, because I think that's where the focus is. I'm not sure there's anything. I think that is the key issue. I mean, right, we're worried about originally we're worried about a virus that has a fatality rate, that has a high transmissibility and a high fatality rate. That's the worry. And as time went on and more data came in, and we had greater testing surveillance, it became clear that the original mortality rates of 2, 3, 4% estimated were not true. And not only that, we have now found out that the mortality risk is very age stratified. But if you see the media, especially here in Canada, daily people are bombarded with the number of new cases, and without much context.
Wow.
And it makes you a little bit worried about, talk about a collateral harm, it makes you a little worried about that sort of daily conditioning of fear that gets out there. And so really what I wanted to portray was just to say, the mortality exists in such a small segment of the population, and the balance of the mortality takes place at an extremely low case fatality rate. And I just remember my own, when I saw this, my own, epiphany
No,
it was that, I don't have to walk around in fear.
That's so powerful. And I have to say, I know what you mean by epiphany. Like when I first saw those data sets broken out by age, a huge burden lifted from me. I mean, it just changes your worldview.
Yeah, and one of the...
Just know what they are. Sorry, go ahead.
Well, and one of the great things that Dr. Kuldorf and his colleagues have done is they've understood this, and they've communicated it very well, and they've really related it to public health policy, which seems to sort of be the missing link here. The public health policy is across the board lockdown to prevent case transmission. Mm-hmm. As opposed to focusing on the true problem.
Yeah, I need to say that again. Adjust your mic.
Okay. So this is what Dr. Kuldorf and his colleagues really do a good job of explaining. They not only do they point out the age stratified mortality risk, but they try to, as best they can, relate it back to health policy, because if we know where the problem is, we know public policy, in my view, being the missing link, we should know how to conduct ourselves and get out of this pandemic much better.
Absolutely. So let me ask a final question. Are people living in fear in Toronto? I mean, are people allowed to go outside? Are they allowed to socialize using good common sense? Are they allowed to go to restaurants? Or are they kind of indoors being fined if they go outside, as people are in Britain? I've seen some scary footage of protesters against lockdowns being beaten by Canadian police. And, I always think of Canada as so sane and peaceful, very shocking imagery. How are people doing in Toronto?
Well, I think we're all just as shocked as you are. In Toronto, so Toronto is under a stay-at-home recommendation order. Businesses, non-essential businesses are closed, restaurants are closed, gyms are closed. Everything's pretty much closed, and schools are closed.
Terrible.
So it's in the context of what we've just discussed. It doesn't make a whole lot of sense.
Not make a whole lot of sense. Truer words were never spoken based on the data, and I've promised all of my readers that I will share these links. So if you'll send me links to the research you've done, or send me some of those spreadsheets broken down by age, I'd be super grateful. Kelly Brown, you've been so wonderfully really done a public service in stepping forward and explaining these data sets to those of us who are not, data scientists or data nerds, or just people who understand data like you. And I can't wait to share those with the community. Absolutely, you're another voice chiming in saying this doesn't make sense. Is there one final thing you would urge policymakers to do based on the real numbers? Open things up? What would you say?
I would say be honest with the public about what their risk is, because there are people here that are at a lot of risk of mortality if they are infected. Mm-hmm. And there's a great number of people that are not at high risk of mortality, and that nuance is not coming through from, in my view, our public health officials, our government leaders, and from the media. It's not coming through.
Fantastic. So message from Kelly Brown to legislators and to the media in Canada: just be honest with people. Thank you so much, Kelly Brown. I'm so grateful to you. And this is Daily Clout, and it's Kelly Brown in Toronto, another Profile in Courage. Thank you so much. Take care.
Thanks, Naomi.
If people want to reach you, where do they find you?
They can find me on Twitter, Rubicon, at Rubicon Capital _, and my DMs are open.
Fantastic. Thank you so much, Kelly Brown.
Thanks, Naomi.